Hi, Dr. Rojas.
Justin, can you
Yes,
hear?
I'm Justin.
Can you hear me well?
Yeah, you sound a little far away from the mic.
Yeah, I forgot to bring my earpiece and stuff, but
Oh, sure.
hopefully this will work this way.
Yeah, it should. I guess if you can stay relatively close or speak up, I think it should be fine.
I do have a microphone.
Okay.
Let me see if that works here. How about now?
Oh,
Is that better?
yeah, there we go. Yeah, except it's a little close. If you hold it further away, I think the mic.
Better there?
There you go. That's good.
Right. Let me, I was in a meeting not too long ago and had that virtual background. Let me move that. All right.
So I'll just be here in the background otherwise.
Yeah, how many people do you expect they're going to be in?
It's hard to say. In the past, anywhere from 25 to 30 have been on. So it could be a decent number.
Then I can just load up from if I share my screen, I can load up from here, right?
Yes, you should be able to just share your screen on your end.
So do you want me to do that now or wait?
If you want to try, that'd probably be good, just to
Okay.
make sure it works. Yeah, I see it. And then I guess once you're ready, you can, of course, there you go. Yep, looks good.
You want to leave it just like that, or you want me to stop sharing?
That's up to you.
I think you should just leave it like that. Then we don't have to worry about any other glitches that could arise later.
That sounds good.
Okay.
Thank you for joining us, Dr. Rojas. Would you like to introduce yourself, or would you like me to introduce you?
You guys call it. I had it sort of embedded, but
You've got it. I'm going to let you. I'm just going to thank you for joining us then. How's that sound?
that sounds great.
All right.
Danielle, I guess you could let me know if there's anything you need. Otherwise, I'll just be hanging out here in the background otherwise.
Thanks, Justin. I appreciate it.
Sure. Thank you.
Okay. A punto de comenzar la charla ahora. Estoy aquí seteando. Entonces, te aviso porque la paciente que venía para cirugía se cayó en el camino y se dio un totazo en la cabeza. Es posible que la cancelen. O sea que sí, si la cancelan, voy para la casa. ¿En dónde tú andas? Por la casa. Ok, está bien. Bye. Sorry about that. You know, I have to report to my wife every now and then.
That's a good thing, Doctor.
Danielle,
Yes.
I wonder if you suppose we should wait till at least 5 after to start?
I'm guessing.
Yeah, it's looking like it might be at least maybe a few minutes after 12. Hopefully we'll get a fair number by then.
That sounds good. Thank you,
Okay.
Justin. Good afternoon, everyone. I think we're just going to wait a couple of moments and for a few more to join. Thank you. I want to thank everyone for joining today, and I want to especially thank Dr. Luis Rojas for joining us and talking about culturally competent care for Hispanics or Latino patients. Thank you, Dr. Rojas.
No, thank you guys for inviting me. It's truly an honor for me to be talking today in this platform. I want to start by saying that I have no conflict of interest or anything to disclose. That is a conflict of interest. And a little bit of my background, I'm a gynecologic oncologist at a Vera health system. I function as the VP of Medical Oncology for the Cancer Service Line. I'm from Hispanic Latino heritage. I've had some experience treating patients of my culture as part of my healthcare education. After I completed medical school, I was required to go to a remote site within the Dominican Republic to care for indigenous and very needy or population that had significant needs within healthcare. Later on, when I was in my residency in Philadelphia, I had the opportunity of be a part of a roundtable that was specifically talking about the challenges of caring or providing the appropriate care for the Latino Hispanic community. I am just mentioning those two things, but I want to definitely tell everybody that I am in no means an expert in this topic. I had to do a little bit of digging to kind of refocus my previous experiences into this talk. What I would like to proceed is outlining that at the end of this, you may be able to understand the proportion and growth of the Hispanic and Latino community within the composition of the United States population. You should be able to identify that what are the most common medical issues that this group is at risk for. And you should be able also to understand what are the healthcare disparities for Hispanic or Latinos facing the healthcare system in the United States. At the end of the discussion, you should finally be able to identify and learn pearls to help provide culturally competent care for the Latino group. I want to start by outlining some important definitions. Later on, kind of discuss how have we gotten here in sense of the growth of the Latino community within the United States, and then finally talk about those challenges and pearls. So culturally competent care refers to healthcare that is sensitive to the values and needs of certain cultural subgroups within our society. And even though we'll be discussing this topic, mainly focus on the needs of cultural groups in a pluralistic society, I would specifically focus on the Hispanic and Latinos. But we need to understand that within the Hispanic and Latino community, there's a lot of diversity. This means that some of the definitions and concepts that we will be reviewing may not be generalized to all members of that community, but rather need to be individualized based on the country of origin of each of those patients. The most important concepts that we need to embrace are what is a Hispanic. Hispanic is basically a person of Cuban, Mexican, Puerto Rican, South Central American, and any other countries, Caribbean, that speak Spanish. Initially, this definition really fell short in globalizing all members of the Hispanic Latino community, because there are members of that community that don't speak Spanish. If you look at the people that live in Brazil, they mainly speak Portuguese. Similarly, there are many members of the community, particularly the natives of South America, that don't speak Spanish at all. They speak very specific dialects. So the term Latino came abroad to take into account this aspect of the definition. This is the most commonly used term to refer to people of our culture, and it is the one that I'll be using for the remaining of the discussion. It basically describes the population whose principal ethnic heritage stems from Latin American countries. So to talk a little bit about, or to get an idea, flavor of what are we talking about, it is important for us to understand the scope of the problem, that we understand that the Latino group, what proportion of the US population do they represent? You can look at that graph on your left. We can ascertain that the Latino minority is the fastest growing group in the United States from minorities. For example, in 2007, we represented 15% of the total population. In 2014, that increased to 17.4%. In 2050, we're expected to grow to be 24% of the total US population, and the prediction for 2060 is 28.6%. So quite a bit of rapid growth. Currently, Latinos comprise the largest minority group in 20 of the 50 states, and in states like California, Florida, Texas, probably they represent more than 30% of the population in the state. So it is important to also note that the US Latino population is quite young in comparison to the population in the United States, with a median age of 27 years in comparison to 36. Moving forward. How do we get here? Well, the growth in the Latino population dates back to the immigration trends in the 1940s. This was specifically linked to the agricultural sector of the US economy. In Mexico, initially, there was a relatively lack of jobs in this industry that drove many Mexicans north in search for work. And in 1942, the Bracero program was established as a guest worker program designed to bring experienced agricultural laborers to the United States from Mexico. This led to an influx of Latinos and immigrants. This actually expanded to other countries like the Dominican Republic, as those Latinos coming for agricultural purposes were doing great, and progressing economically and in their lives. Then other countries followed through. Unfortunately, once the program disappeared in 1964, and despite the proclamation of the Immigration Reform and Control Act in 1986, the influx of Latinos continue illegally. I can tell you that for my country, the passage to the United States was traveling illegally by sea between the east side of the island to Puerto Rico, and then from there getting to the United States. Similarly, through Mexico, a lot of people just migrated illegally. And these conditions meant extreme hazardous situations for the migrants. To understand what are the specific risks that this population currently has, the trends in hardship that make them come over are amongst the most important factors that have made Latinos particularly at risk for certain diseases like diabetes, tuberculosis, hypertension, HIV, AIDS, increase in the trends of alcoholism, liver cirrhosis, death from violence, sexual assault, amongst other things. To make things worse, the disproportionately high prevalence of delay in acute care in the treatment of Latinos have also resulted in lack of effective medical treatments for them. Reasons contributing to this are this is a particularly impoverished population that lacks health insurance and has multiple social and cultural factors that and beliefs that result ultimately in delay in the individual seeking a medical provider. On the right of the slide, you can see a comparison of the 10 leading causes of death for non-Hispanic whites in the United States, and to the right of it, what Latinos typically suffer. It is worthwhile mentioning how diabetes and chronic liver disease creep up in the Latino group. But part of the scope of the problem exists given the fact that in spite of a large and rapidly increasing size of U.S. Latino population, there has not been a corresponding increase or influx of Latinos within the work U.S. healthcare force. So this added to the delay in medical treatments, the particular impact along the linguistic barriers and cultural barriers eventually results in a healthcare disparity. In fact, it is a fact that that mostly in the 1990s, now this is being corrected, the Latino culture is the most underrepresented major minority group in the United States healthcare force. So as you can see, and just trying to be simplistic, the scope of the problem can be summarized as a coalescence of language barriers, healthcare access, and healthcare delivery disparity, and social and cultural factors that ultimately result in a lack of culturally competent care for the Latino minority. The barriers in cultural competent care can be overcome if we understand what these barriers are. So I'm going to first start talking about some facts regarding language. 60% of Latino adults primarily speak Spanish at home. I can tell you that me and my wife were from Dominican Republic, and that's all we do at home, which for our kids that are growing in this country and learning English is an advantage because they speak the language not as good as we do. But that doesn't happen in all families. Professional Latinos tend to be very conscious about the value of education and force themselves to, learn the language. But the biggest part of the group doesn't. Just understand that, for example, Latino residents in the United States that are 5 years or older speak English very well, but the adult Latino that has been here for years speaks English not well or not at all. This has significant consequences, obviously, particularly in healthcare, because the patients that present to the healthcare facility typically report feeling less listened to, and that's just a perception due to the language barrier. They understand their providers less common, and they leave those visits with the providers with twice as likelihood having questions that are not answered. Overall, this translates into a sensation of being treated unfairly or neglected. Um, these language barriers and gaps in care and dissatisfaction become even more troubling in the context of significant disparities in access to health insurance and to the healthcare system in general. The poverty rate, for example, for U.S. Latinos is 20.8%. Compared to 12.3% of the overall population. Moreover, 30% of U.S. Latino lack health insurance in previous years, compared to 15% of the general population. And nearly half of them reported not being insured at some point in their life, or being uninsured at some point in their life. Amongst insured Latinos, there is a higher likelihood of coverage inadequacies from the insurers. And it is important to note also that greater than 10% of Latinos typically obtain clinical care in an ad hoc basis. And there are some cultural factors behind the lack of belief in preventive therapies. And so as a consequence, there are other cultural factors that play a role in their healthcare, like folk medicine, the use of traditional healers, which limits the kind of care that they can get. There are important cultural values that need to be understood that play a big role over here. The concept of simpatia or sympathy, which is a politeness and the avoidance of hostile confrontation, is something that plays a significant role. Hierarchismo, or the respect for hierarchy, is a very important cultural factor within the Latino community. Personalismo, or personalization of care, which means, they expect a warm personal interaction once that rapport and trust has been established. I can tell you, for example, being an OBGYN by main career, in my country, it is expected that the person that starts the prenatal care will finish the job and do the delivery, something that, for example, here in the United States is not accustomed, because we have very complex medical systems, and the person on call takes care of the delivery or the end of the pregnancy. The concept of presentism, the Latino community emphasizes and lives in the present. They not necessarily pay much attention to the past or the future. The concept of respeto, or respect, is very important. And the importance in the community, the Latino really gives importance to showing respect to authorities, to the physician, to the healthcare provider. The concept of fatalismo, or fatalism, which is the belief of the Latino culture. They believe in the Latino culture that individuals have very little to do to affect fate. And the concept of spiritism, or spiritismo, which is the belief that good and evil affect the well-being of the person and overall the soul. I left for last the concept of familismo, which is actually one of the most important concepts that influences the Latino culture. And this basically means the subordination of personal interests and prerogatives of a particular individual to a secondary place on top of the demands of their family and their community. So on that particular aspect, this is probably the most important cultural value that has a role in the realm of healthcare. It is typically a family-centered decision making that goes on related to when somebody's making decisions for their health care. Typically, the maternal figure in the family determines when medical care is warranted, and the paternal figure, which not necessarily is the father, but may be the oldest male, provides sort of grants permission for a family member to seek health care. Those are some of the interesting cultural values that affect the Latino culture. In the next two slides, I just want to read a couple cases that we have selected to use to exemplify what the average Latino member of the Latino community can go through. And the first case is a case related to pregnancy. AL is a 17-year-old illiterate farm laborer, originally from Mexico, who speaks no English and speaks very little Spanish, as she speaks Mixteco, which is a dialect from Mexico natives. The patient's admitted at 36 weeks with vaginal bleeding, a diagnosis of placental abruption, and the best way to salvage the situation is a cesarean delivery. Consent is emergently obtained, but concerns of whether the patient understands are present given that no one speaks her dialect. After the cesarean delivery, the baby has to be transferred to the neonatal intensive care unit due to encephalopathy, small for gestational age, and low APGAR scores, which is how we measure how babies are doing immediately after birth. The patient is with her mother and her sister, who also do not speak English or Spanish. Her husband, who initially did not present with the patient, given fears of losing his jobs due to missed work, eventually arrives and is able to speak with the staff, given the limited Spanish that he speaks. A Spanish-speaking social worker meets the couple and discovers that they have no insurance, receive no prenatal care before presenting to the clinic with the emergency. They do not have resources even for prenatal vitamin, and the only access to care that they may have experienced was through a mobile free health clinic. The patient had worked in the farm fields until the day before presenting to the hospital. The social worker is actually very concerned about pregnancy exposure to harmful pesticides and ascertains the patient has no legal migrant status. Once the patient stabilizes, she's able to go to the intensive care unit with her husband, and through the translator are able to communicate with some limitations with the staff. The patient shows very little emotion, somewhat an aloof demeanor, and has a flat affect. The neonatal intensive care unit staff is concerned about how much is the patient understanding about what's going on and how much does she truly care about her sick baby. The patient's mother and sister get the husband to request that the baby gets visited by a curandero, or a traditional healer from their community, as they are requesting the baby to undergo cleaning with an egg, which is a typical ritual that is used in certain Mexican communities for babies that are not doing well after birth. The nurse, in a forced tone, reminds the patient's husband that the baby is too weak for alternative treatments and that they are receiving state-of-the-art clinical care at this point. The firm tone of the nurse distresses the husband and the family, and after the nurse notices this, she softens her demeanor. After several days in the hospital, the patient gets discharged while the baby remains in the NICU. Over the next couple of weeks, the baby stabilizes, but the extent of the neurological improvement and potential damage is unclear. Eventually, they get discharged with the baby to go home, unsure about the future. As we can see in this example, there are multiple challenges to culturally competent care that goes from the illiterate status of the patient to the fact that they don't speak Spanish or English. As we can see, the family is present and kind of drives their decision making and requests for what in their view are their healthcare needs. They have no insurance. They are obviously living in poverty and have not received any previous prenatal care. In fact, they are illegal aliens. The flat affect really reflects not necessarily that they don't care about the situation, but rather that they don't understand it. As they don't understand, they go back to the roots and get requests for this traditional healer within the culture to come and provide care for the baby. The second example is a little bit different, and it's about an end-of-life case. Gabriela Rivera is an 80-year-old New Yorker, originally from Puerto Rico, who have lived alone in a rented apartment for 40 years, and she barely speaks any English. She's a devoted mother that calls her children as often as she can afford, and has raised her children throughout their teenage years in the same apartment which she lives today. She struggles to make rent, but receives financial help from her children. Gabriela suffers from high blood pressure, type 2 diabetes, and control these medical ailments with diet and the medication whenever she can remember or afford them. Most recently, she has experienced a decline in renal function. Her youngest, Marcos, who is 49, lives close by and speaks fluent English and Spanish. He is a dedicated construction worker who has 3 teenage kids that help grandma at home. Marcos himself is a moderate to heavy drinker and has also recently been diagnosed with diabetes, a problem that he's really not addressing because of his fear of needles. Lately, Gabriela has experienced persistent cough, headaches, shortness of breath, and a general sensation of feeling ill. She has been ignoring these symptoms for a while. One afternoon, on her way home from work, Marcos' wife, Maria, received a panic call from their daughter, who has shown up after school at the grandmother's house to find her acutely ill, dizzy, anxious, and having severe difficulty breathing. Maria hangs up the phone, calls 911, and rushes to the hospital to meet the ambulance. Gabriela's initial workup reveals severe COPD and bilateral pneumonia. In addition, the blood test shows that her diabetes is under it's totally out of control, and her kidney functions are less than normal capacity. Once Gabriela has stabilized with oxygen by the attending in the emergency department, who speaks English only, talks to Marcos, Maria, and Cecilia, and recommends the patient is admitted to the intensive care unit. In the intensive care unit, the physician over there, who also speaks English only, attempts to discuss with Gabriela, amongst other things, the option of a do not resuscitate order. But as soon as the doctor assesses the patient, determines that she's not capable of making this decision at this time, reason for which he approaches her son, Marcos, on the matter, explaining that patients in such conditions as Gabriela, the chances of resuscitation will restore the patient to previous quality of life in a very small circumstance, in very small percentages. Marcos, however, vehemently forbids the DNR and insists that this is not mentioned again in front of Gabriela. After much discussion with specialists, further assessment and discussion of potential hospice, as the patient doesn't qualify for life-saving therapy, goes on. Maria, Marcos' wife, simply looks at the floor, yet Marcos abruptly and angrily burst out that his mother is not dying and that God will certainly protect such a saintly woman through this time of trial. He also insists that they are perfectly able to take care of her needs as a family and that the doctor should focus on other matters besides hospice. In this second case, we notice, again, many barriers to providing appropriate care for the patient. The language barrier, the poverty, the lack of access to care, the lack of access to medication. And we also are able to see at the end how religion plays a role in the mind of the Latino culture by understanding that God will take care of everything and not really focusing on the facts. So in this part of final part of the discussion, I really want to highlight some pearls that can help the healthcare provider provide culturally competent medical care for the Latino community members. We have to understand that in this culture, people do not appreciate familiarity or physical contact by strangers. That changes once proper rapport has been established. It is very common not to use first names or be accepting of casual verbal conversation. So respect is very important. We notice that as typically the elder prefer to be addressed by their last names. It is better to avoid gestures as they can be misinterpreted. And it is a must continuously during the interaction with a Latino patient to evaluate whether or not they're understanding of what is being said, and doing this by encouraging the patient to ask questions. Rapport with the patient typically gets built by exchanging pleasantries and making them feel comfortable. It is recommended for the healthcare provider to have a warm and personal demeanor. We got to understand also the signals that come from the patient. A nod or a yes doesn't really always means that they are understanding. Silence may mean not understanding or disagreement. And typically disagreement or this kind of silence will translate in non-compliance. The important thing though is to understand that authority, the physician, the nurse practitioner, the healthcare provider will not really be questioned by the Latino community. They will respect their opinion, except as you saw in the second case, in dire circumstances, particularly the end of life. It is important to understand that eye contact with the healthcare provider doesn't mean that it's a sign of respect, not a sign of disbelief. It is also very important to understand that when a Latino patient comes with a family member, it is even if the family member speaks English, it is better to utilize an interpreter, as family members are really not comfortable discussing certain topics, particularly if they are members of the opposite gender or younger. Perils related to social structure understanding. A family in the community are the most important social and supportive entities. And it is important to understand that the concept of familismo is characterized by interdependence, affiliation, and cooperation throughout the family. The need of a family takes precedent than the individual need. There are certain expectations that are interesting. The elder expect their children to provide support and reciprocity. They may rely on informal support networks and family care after a hospitalization more than actual formal support provided by the healthcare system. Let me give you a personal example. I remember when my grandfather, who was a general surgeon in an educated family, tradition of physicians, what have you, when it was his turn to reach that age where end-of-life care was needed, we normally take care of our own. I had my grandfather being cleaned up and helped by myself and my mom, who was her daughter-in-law. This is sort of an expectation. We really don't have, long-term care or nursing homes where we put our family members. Important decisions related to healthcare are made as a family typically. The family typically bears bad medical news before actually telling the actual patients. That happens very commonly in our culture, where when there's a diagnosis of cancer, the children know it and may decide not to convey that news to the family member. It's a cultural thing. And then typically there's a spokesperson within the family that is responsible for delivering bad news. There are certain roles that are important to understand. The father or the father figure is responsible to provide for the family and be in charge of the family. The mother is the one that determines typically medical care when it's needed. And the male head, who doesn't have to be the father, could be the oldest male adult, is typically the person that gives permission to seek that health care. The wife, though, or the mother figure, typically holds the family together and is the primary caregiver and most responsible for parenting the members of the family. If we want to be successful in providing culturally competent care, we have to encourage the healthcare provider to engage in family meetings, identify needed resources by the members of the community, of the family, and provide whatever needed education is identified. On regards to pearls related to how the Latino community views disease, it is important to understand that there's a different perception of how illness occur. There is the perception that illness occurs due to an imbalance of internal and external factors, typically an imbalance between the person and the environment. And diseases are typically perceived as hot or cold diseases. So cold diseases or conditions are those that are somewhat characterized by vasoconstriction or low metabolic rate. So for example, menstrual changes, rhinitis, pneumonia, abdominal colic, and home remedies to counteract those diseases are typically focused on the use of hot medication or hot remedies. Vice versa, hot diseases or conditions are typically those related to vasodilation or high metabolic rate. So for example, pregnancy, high blood pressure, diabetes, indigestions are considered hot conditions and are typically managed with cold therapies. There is a perception within the community that the patient is a victim. So the family nucleus tends or expect the patient to be passive during their ailment, and they even take care of helping the patient through the activities of daily living while they're sick. Mood disorders are perceived as an embarrassment to the family, and typically clergy help in managing this kind of mood disorders. When somebody gets told they have depression, that is a sign of weakness for the culture. And disease prevention is really not well valued due to a lack of participation. And this is typically due to the idea that an illness is sort of a punishment for past deeds that inhibits the Latino community into therapeutic or preventive strategies. It is important to know that asking about or listening to the cultural beliefs helps establish rapports and shows respect and opens the patient to the care. Almost finalizing here, folk medicine really plays a big role. Folk healing shows is a blend that mix in their own religion. Typically, that is instituted in early life, and later on in life, as the Latino community members grow up, they accept more conventional medicine mixed with home remedies and other religious beliefs. There is usually sought out the alternative medicine practices like chiropractic strategies, masseuse, acupuncture, herbs. And cost of medicine have a big impact in the community. Home remedies and over-the-counter medication are preferred because of the high cost of conventional medicine. Cost of medicine also have a significant impact in medication sharing within members of the family. So for these purposes, traditional and other additional type of medicines are most preferred. On the right of your slide, you have common names for the alternative healers that the Latino community uses. For example, in Mexico, they call the witch doctor or the alternative healer a curandero. In Puerto Rico, Dominican Republic, we use some faith healers. They call that a spiritista, based from the spirit. In Cuba, the saint or faith healer is called a santero. They also use people that focus their care on herbal medicine. They call that a yerbero or a herbalista. The masseuse are called sobadores. And pregnancy care, prenatal care is solely focused at the end by somebody that's usually a female called a partera or a midwife. There are some other members of the common alternative healers that do not focus on the spiritual care, and they only focus on nature remedies, and they are called naturistas. Finally, religion plays a big influence. Spiritual and religious influence is a major component of health and illness for the Latino culture. It has a vital impact. Church is very central to the life of the family and the community. Faith and church are very powerful sources of hope and strength, and prayer and faith are very important values, beliefs, and coping mechanisms, to the point that it's very commonly to see an altar in people's homes, living rooms, bedrooms, like you see in the picture in front of you. These altars have pictures of saints or other important religious figures and candles that are lit 24/7 as a significance of sustained worship. There is the belief that good and evil spirits affect the well-being of the patient, of the person, and the soul. And we have to understand from the religious aspect of things that Latinos are mostly Catholics and Christians. So vital rites that are very important are baptism and the anointing of the sick. Finally, to conclude, I think it's important to understand that there are several constraints to cultural competent care for Latino patients. The most important are difficulties in accessing care, along with poverty, language barriers, and all the cultural aspects that I just touched upon particularly the concept of familismo and faith. It is important for the healthcare provider to be familiar with the range of belief systems found in the U.S. Latinos. Yet it is imperative not to assume that based on the ethnic background, a particular individual maintain those traditional beliefs. I think it's important for healthcare provider to be cautious and not to oversimplify these values, customs, and beliefs that characterize a big ethnic group that is very diverse within it. I think important to individualize each particular case. I think at this point, I'm going to leave it over here. I don't know if anybody in the call has any questions. I'm open for it now or later on if somebody does.
Thank you, Dr. Rojas. There's nothing in the chat. I've been watching that, but if anyone has any questions, please feel free.
Oh, thank you, Dr. Rojas, for your presentation. My background is in law. I spent a couple years in Honduras, so I try to use my Spanish to serve the community and do some work with Caminando Juntos. So part of what I see when I work with Spanish-speaking clients is there's a tendency to shy away from creating advanced directives, from creating a healthcare power of attorney or a will or some sort of documentation that would require significant information. I don't know if, maybe that's the community that I work with, or if it's the Hispanic community in general. Could you speak to advanced directives a little bit? Is there a tendency to shy away from creating them, and what would be a good way to encourage more creation of advanced directives?
Thank you for the question. That's an excellent question. Actually, I work with Caminando Juntos all the time with the community. I actually give these kinds of educational talks to the community, and yes, advanced directives is a problem, and I think is very linked to the level of education of the patient. We see within our culture that the less educated you are, the less open you are to advanced directives. I can tell you right now, I have a patient who's finally on hospice, and it really took me, she's a cancer patient that I've been following for a long time. It really took a lot for me to get her to commit to some advanced directives. I think it's a fear that it's a misunderstanding that if you have those documents or advanced directives, you are not going to be cared for, and rather are going to be left out if you get sick. But there is definitely a correlation with level of education. The more educated, if somebody has a technical education in their life or a more professional education, those individuals tend to be very open to advanced directives. To circumvent that, what I have done with my patients is really, it takes a lot of education, ideally by somebody that speaks the language, to making understand the benefit of that. I mean, as a lawyer, maybe if you have somebody that is fluent in Spanish, you'll be more successful to get those individuals to open up to that. I'm not sure that I answered your question.
No, you did. Would you mind if I reach out to you? We're actually kind of working towards a clinic to serve Spanish-speaking community and provide sort of a free legal service to provide those directives. Would you mind if I reach out to you as that comes into fruition?
Yeah, I'm open for anything that can help the Latino community here in Sioux Falls. As I told you, I've worked many times with Caminando Juntos, and that may be a good topic of discussion for the community. What does that mean? What is advanced directives? It's interesting because it's the same group of ladies that show up to learn, and I have told them many times when we're talking about family-oriented clinical topics, bring your spouses, bring your family, and the mother's always there and nobody else. But definitely, that's I'm more than happy to help.
Okay, thank you, and thank you for your response.
Any other questions?
So I have another one. If no one else is stepping up, I had recently listened to a podcast on a person who qualified for DACA before some of those restrictions were or in place, and had gone to medical school. Is there a way to encourage some of the young people to follow the path of medicine? You know, you had said there's not enough medical professionals to serve the population. Do you have any insight on how, whether through legislation or whether through medical community or, you know, departments of education, that would encourage young people to seek the doctors or medical providers?
No, I think that's a great point. I do believe that the challenge of medicine is that, you know, you have such an array of or healthcare of opportunities. So I think starting in the high schools with education about all the potential opportunities that are here, for example, in the United States, in our countries, when you finish high school, you have to commit to a path in healthcare. It's not the whole gamut of healthcare careers that are here in the United States. You know, you can go to nursing, you can go be a clinical technician, you can be a nurse practitioner, you can be a nurse anesthetist. In our countries, the path is a long path, and it's a path to being a physician, and not everybody wants to do that. And the Latino community here in the United States sort of gets that understanding, that misconception, or the lack of knowledge of how many opportunities we have here that are a shorter path within healthcare is not understood by their parents and the children. I think, like, have more than legislation, having entities like Avera has a program now that's reaching out to schools and kind of getting those high schoolers more ingrained into the system so that they get interested in several different healthcare possibilities or availabilities. But I think it's going to be more an education, in my opinion, an educational process of reaching out to high schools to sort of promote health interests within the young community.
Dr. Rojas, this is Michelle, and my question for you is, if we're doing like a cultural competency assessment, what are your thoughts and the appropriateness of assessing a family's use of alternative healers and the role of their perhaps religious leader, and would you invite those people to attend family meetings if they are utilizing those as support resources? Oops, you're on mute, Dr. Rojas.
Sorry about that. I think that that's very appropriate. In my experience, I'm going to tell you what has worked, particularly in my field, which sometimes is a challenge whenever that is an issue. We are more successful with the individuals opening up or, pursuing what they need to pursue, as long as we allow to have both things. You know what I mean? We see very common the patients are more compliant with their ideally evidence-based recommended care if we sort of say, yeah, I'm okay if you take your herbal medications. And what we do in healthcare, in our field, for example, we make sure that there's no interactions or potential issues with the treatment. I'm pretty sure that the same will be if we want to, and I don't know if I'm answering your question right. If yes, educating and bringing them on for that kind of counseling or education, so to speak, will be important, as long as those beliefs are going to be there and they're kind of being respectful of them. Will be you will be more successful at achieving your goal.
Thank you.
Okay. Well, if somebody has any questions later, I'm more than available. Danielle can facilitate my contact. Always open to contribute.
Thank you very much, Dr. Rojas.
Okay. God bless everybody.
Have a good day.